Good evening. This is the second part about malignant tumors of nose. So, yesterday we talked about the most common malignancy of the skin of external nose, that is the basal cell carcinoma. And today we're going to talk about the most common carcinoma of the nasal cavity, which it is the squamous cell carcinoma. This is most commonly arising from the lateral wall, and it can also arise from the septum, and when it is known as nose pickers carcinoma, and it is managed by a combination of surgery and radiotherapy. Another malignant tumor is the Esthesio Neuroblastoma, and it is a rare malignancy and constituting only 1 to 5% of nasal tumors. So it arises from olfactory epithelium lining upper 1/3 of nose, and it has bimodal age occurrence with two peaks. The first peak is from 11 to 20 years, and the second peak is from 55 to 60 years, and it commonly spreads to orbits laterally and brain superiorly. And the most common cranial nerve involved here is olfactory nerve. So, it is a neuroendocrine tumor and can secrete hormones. So, before excision serum and urinary catecholamines should be tested. Metastasis to neck is seen in 10 to 20% cases, and it is managed by combined modality treatment with surgical resection, which may involve local resection or craniofacial resection with postoperative radiotherapy. The paranasal sinus carcinoma. The most common carcinoma of the paranasal sinus is a squamous cell carcinoma too, and it is seen most commonly in maxillary sinus, followed by ethmoid, frontal, and sphenoid sinuses. So there is a specific history of exposure to nickel, chromium, and lead. And the squamous cell carcinoma of the maxilla presents with blood-tinged nasal discharge and nasal obstruction, the widening of upper alveolus leading to poor fitting of denture, pain and loosening of teeth, epiphora, which it is the watering from eye, and facial paresthesia. And palpable lymphatic metastasis is uncommon, and primarily maxilla drains into retropharyngeal lymph nodes, which are inaccessible to inspection and palpation, and secondary localization of metastasis occurs to submandibular and upper deep cervical lymph nodes, and hence palpable metastasis. And lymphadenopathy is a sign of advanced disease. So, in people working in wood furniture industries, the most common carcinoma is the adenocarcinoma, which is more common in the ethmoids. The classification. Ongoing classification put an imaginary line is drawn from the medial canthus to the angle of mandible, dividing the maxillary antrum into a supra and an infrastructure. And this classification states that the carcinoma of suprastructure has poorer prognosis than the infrastructure. So this is because the carcinomas the suprastructure can easily spread to the orbit and base of the skull. And TNM classification about carcinoma maxilla. For T1, the tumor is confined to antral mucosa with no bony distraction. For T2, bony distraction involving medial wall, for example, the medial meatus, and inferior walls like the hard palate. And T3, bony destruction of posterior wall of maxillary sinus and pterygoid place, superior wall and floor of orbit and amos sinuses, and laterally infratemporally fossa, and anteriorly subcutaneous tissue and skin of cheek. And T4 when the tumor invades orbital contents like orbital apex, cribriform plane, base of skull, nasopharynx, and frontal and sphenoid sinus. And the treatment for nearly all patients of maxillary carcinoma, the treatment is surgical resection followed by radiation therapy. And the surgical resection can be a partial or totally maxillectomy. And the incision used here is the Weber-Ferguson incision or a mid-facial degloving approach. After giving a sublabial incision from one molar to the other, the skin flap is raised over the face and the procedure is carried out. Only small like T1 mucosal carcinomas can be treated by surgical resection alone.